And it's probably once a week now in my practice, I'm seeing a patient or a family who says something like, I've been on 15 medicines, I've seen 4 different neurologists, and this is the first time in years that we've heard that surgery could be an option. And I'll show you some cases and some stuff, but surgery tends to be a really good option, and in this modern era, I would say it's quite safe. So the first one is an 8-week-old girl who was referred to me. She was having 80 seizures per day. I'm now at the age where I have to take off my glasses too. So her MRI showed something called hemimegalencephaly, which is they get such frequent seizures early in life. If you don't operate on them, they end up progressing to sort of what I would call maybe an autistic phenotype. They're often nonverbal, but it's an anatomic defect, and so it is amenable to surgery. And this child was already tried on maybe 6 meds, as I mentioned, 80 seizures a day, and they ended up coming back to us. We admitted them, and I ended up taking this child for a hemispherectomy at 8 weeks of age. She's actually not the youngest that I've taken. She's seizure free. She stayed in the hospital for about a month. Pretty complex case. I had to do it in 2 stages. But the child looks great. She's being weaned off all of her epilepsy meds, still seizure free. And if you looked at her, you would see that she has a little weakness in one hand, and one leg is, I would say, a little bit more dynamic than the other. But all of these patients should walk fine. And so hemispherectomy is still one of our most powerful surgeries in terms of getting seizure freedom. If you look like this and you have a destroyed hemisphere on one side, chances of seizure freedom with surgery are like 80 to 90%, better than temporal lobectomy for epilepsy. So one of the most powerful surgeries we have. And basically this surgery starts with, I make a cut and I just simply lift out that temporal lobe. So that's gone. And then you see the other part of the surgery is this cut. This cut goes all the way down to the midline and functionally disconnects the parietal occipital lobe. So I'm just going to orient you. Here's the temporal lobe of the brain. This is what the CT looks like. Obviously the temporal lobe is gone, but then this is the other critical part of the surgery is this cut. It's a disconnective cut. As you can see, the parietal lobe's still there, the occipital lobe's still there, but it's been functionally disconnected. Language mapping is still the one mapping that we need them to be awake. And we actually just did one of those surgeries, believe it or not, in Ukraine about 2 weeks ago. I did an awake surgery for language mapping, but extraoperative mapping. So if I really want to know where language is, I put a grid on. In surgery, then we wake them up, and at the bedside with the grid in the brain, we can map language. So that's, I think, the better way to. Temporal lobe epilepsy, when I was a resident, this was the majority of the epilepsy surgery we did is temporal lobe epilepsy. Now I would say it's the minority, but I do still see mesial temporal sclerosis and other lesions in the temporal lobe that require temporal lobectomy. And this was read as a normal MRI, but it's clearly not normal. And this kid got a temporal lobectomy. So surgical outcome in MRI negative temporal lobe epilepsy is just as good as long as the PET is lateralizing, is just as good as the outcomes from mesial temporal sclerosis. So I also do a lot of callosotomies. So callosotomy is one of the surgeries that we do for generalized epilepsy. So this is not often curative, but it can be highly palliative. And so again, it's a powerful surgery for a wide range of epilepsies, mostly generalized type epilepsies, not just drop attacks. Most neurologists say, if I have a kid with drop seizures, I'll send them to you for callosotomy. But it turns out it helps for generalized tonic-clonic and what we call atypical absence. Anybody with infantile spasms, Lennox-Gastaut, West syndrome, there's a number of indications. And again, I've done some what we call posterior selective callosotomies. They create destruction where the red tip is, but so you burn and then you can pull it back a little bit. So the way this will work is
it leaves like a track.
Exactly, it leaves a straight line track. So that's why what you see is they've used enough of these in straight lines to cover the whole corpus callosum. And this is what the laser looks like when you do it in the actual MRI machine. The other reason we use lasers is for mesial temporal structures. So he was told that the wait time for epilepsy surgery is like 2 years. And this kid, mom told me, she said, I kept a very clear diary. She's a very sophisticated mom and dad and smart lady. And she said, I kept a very strict diary of how many seizures he was having. And when he had 1,000, I started looking outside of the country for options. And they ended up reaching out to us. He had very interesting surgeries, seizures. His seizures were all coming from the insula. We ended up burning his insula, and he's doing quite well. So right now, almost everybody gets 2-stage epilepsy surgery in the United States. Some people are upfront callosotomy candidates or upfront hemispherectomy candidates, but most people get SEG first, so you can see what it looks like. I use a robot. I place these little depth electrodes. I don't cut their hair. You can see with the, so the hair is still there. You just put these little, so it's quite minimally invasive. The pain's pretty minimal. Kids usually a day or two, they might have, you have to go through the muscle here, so they have like a little bit when they chew, it hurts. But for a day or two, they have a little bit of pain, but they really tolerate it quite well. Tends to do a very small dose of something right into the brain, and so they actually have pretty good results with it. And so that's something that's down the pike. And that's it. So again, I don't know if there are any maybe questions or discussion, or if you have any interesting patients you want to talk about, I'm happy to do any of it. And I'm going to take some food now too.
Yeah.
Well, I'll tell you, even when I try to see